Hi guys, my name is Sharad Patel. I am an intensivist at Cooper with interest in echocardiography, diastology, and the works. And I'm going to be doing a brief talk on diastology in the ICU. All right, so most of the slides, the graphics, the images, it comes from this guideline paper for diastology. Easy to find if you just type in Sharif Nagwa, and you'll find the ASC guidelines for diastology, and there's a lot of useful information in there. So when I'm thinking about diastology in the ICU, we understand systolic function. We talk about it all the time. But when I'm trying to figure out what is the utility of understanding someone's diastolic function, I'm thinking about, is there an impairment? Number one, is there an impairment in relaxation? Is there an impairment in relaxation? And if it's impaired, I'm trying to figure out, if you have impaired relaxation, is the filling pressure elevated or not? Now that's the key, right? So if you have impaired relaxation and you have normal filling pressures, it may not be as useful to you in settings where you're trying to figure out why someone's hypoxic and they have pulmonary edema, right? So if they have normal filling pressures and you have pulmonary edema, for example, that may be a situation where you have non-cardiogenic pulmonary edema. So I take that back. It's helpful, but it gives you different information. So is there impaired relaxation? That tells you that someone has diastolic dysfunction, and then you're trying to figure out if they have normal left atrial filling pressures or elevated left atrial filling pressures. So these are the diastology guidelines. It looks complicated, but don't worry, I know it looks confusing, but we're going to try to focus on a few things that are useful to us as intensivists rather than what would be useful to a cardiologist. So again, let's go back to the question of, is there diastolic dysfunction? So I like to, when I'm thinking about diagnostics, I try to think in terms of Bayesian reasoning. So I try to think, I'm looking at this patient, before I do anything else, what is my pretest probability that this person has impaired relaxation? And again, I'm assuming I have a clinical question in mind, whether it's shock or it's hypoxia and pulmonary edema. So if I'm going through my Bayesian reasoning, I have my pretest probability, I have new evidence, and then I have a post-test probability. And so the new evidence is basically telling me, based on this evidence, does my pretest increase or decrease? Or my post-test increase or decrease? So, for example, let's say in all the population, there is a 15% incidence of diastolic dysfunction. Again, I'm just throwing that number out there for just an example. If you have someone who's 80 years old, the likelihood ratio or the evidence of them being 80 years old would increase your post-test probability of high diastolic dysfunction very high. Most 80-year-olds will probably have impaired relaxation and diastolic dysfunction. So that would make your post-test probability go up significantly. Then you add hypertension, end-stage renal disease, diabetes. You go through the same process each time, coming up with a new post-test probability. If you have 80-year-old with all three comorbidities, you probably have close to 100% post-test probability of diastolic dysfunction. So that helps you as you're going through, as you see findings, you're saying, okay, this is within the context of someone who has impaired relaxation. You go to 2D imaging. If someone has LVH, large left atrium, again, your likelihood ratio will be high and your pretest will jump up to a high post-test probability. And then to get more of the nuanced approach of whether there's diastolic dysfunction, you get to Doppler. But by the time you get to Doppler, you should have a understanding of that this person has a high pretest or not. So let's take this example right here. So I have a 75-year-old patient with end-stage renal disease, hypertension, and diabetes. Let's watch this video. Now, you look at this video, and it's a short clip, but you immediately recognize, so it's a subcostal image. You have your right ventricle, right atrium, left ventricle, left atrium. you immediately notice how generous and large these atria are, right? So they're very large. Now, just by that self, for the diastology criteria, left atrial volume index is one of the criteria, which I'm not going to focus on. But for us, it's going to be more qualitative. Does there significantly enlarge atria or not? Here, the atria are very large compared to the overall left ventricular, right ventricular sizes and volumes. So immediately, I think this person has a very high pretest probability of diastolic dysfunction. Already beyond the fact that I have a 75-year-old end-stage renal hypertension diabetes, my pretest, even before I look at anything else, probably close to 100%. Then I add the large left atria, and then I'm finally looking at look at how thick these left ventricle and right ventricle are, right? So this person, I would probably be thinking this person has like amyloidosis or something, and that's probably why they have this degree of pathologic findings. But this case right here, even before I look at any Doppler, is going to have a likely 100% probability, post-test probability of diastolic dysfunction. Now, let's try to keep it simple. So this is kind of my approach to diastolic dysfunction. First of all, I ask myself, what is the question? Why is my patient in shock? If that's the question, I'm going down a certain type of reasoning. And again, why is my patient? The other question might be, why is my patient hypoxic? And again, you may have both of these things, but both of these things can be assessed using diastolic dysfunction as a pathologic finding that may be contributing to it, right? So I have my question, and then I'm looking to see, is my EF normal or abnormal? Now remember, ejection fraction is not the end all. You can have a high ejection fraction and a low cardiac output. So remember, people with a high ejection fraction doesn't necessarily mean that they have a normal cardiac output. For example, if you have someone who has, because the stroke volume is what's basically going to tell you whether you have a high cardiac output or high inotropic activity or not. So your ejection fraction is the ratio of your your stroke volume divided by your end diastolic volume. Now, if you have a small end diastolic volume, you're at any given stroke volume, you're going to have a high ejection fraction. But if your stroke volume is low, in the end, your stroke volume is low. So your cardiac output is also likely to be low at any given heart rate. So ejection fraction is not the end all. But for me, when I'm thinking about diastolic dysfunction, I go down different paths depending on whether the ejection fraction is normal or abnormal. So if you have abnormal abnormal ejection fraction, or if you have systolic dysfunction, you 100% have diastolic dysfunction present. You cannot have systolic dysfunction without diastolic dysfunction. Now the converse is not true. If you have normal ejection fraction, again, we know this, you don't necessarily have normal diastolic dysfunction. This is where it gets a little bit more complicated. This is where you use the ASE algorithm to try to figure out, does this person have impaired relaxation or not? Again, remember to go back to your Bayesian reasoning, the age, comorbidities, and that'll help you figure out if someone has impaired relaxation. Now, if you're trying to figure out by Doppler if someone has impaired relaxation, let's say it's more of a subtle case. It's a 50-year-old with only hypertension and not major LVH, and you're trying to figure out if someone has impaired relaxation. The first thing I like to do is actually tissue Doppler. Now, I'm assuming we've already had a Doppler talk, but again, the tissue Doppler is essentially just measuring the velocity of the tissue moving up and down. And if this value is low, the cutoff being 8, if it's less than 8 at the medial mitral annulus, you're likely have impaired relaxation, your E prime. If it's less than 8, you're likely impaired relaxation. So that's already answered your question. And then you're just trying to figure out if someone has high filling pressures or not, which we'll talk about. After that, if I have impaired relaxation, I'm trying to grade the diastolic dysfunction. I'm not grading it just to grade it, but this actually helps me figure out if someone has normal or abnormal filling pressures or not. And then finally, I try to integrate with lung ultrasound. So oftentimes in hypoxia, there's pulmonary edema. I'm trying to figure out if the pulmonary edema is cardiogenic or non-cardiogenic, and diastology will help me figure that out. So if someone has normal LVF, again, this is the more complicated one because systolic dysfunction always has diastolic dysfunction. I'm looking at these parameters. Now, this is from the AIC guidelines. I will show you a little bit more simplified versions of this, but the ASC guidelines say an average E to E prime, which we'll talk about, but the septal E prime velocity, which I just talked about, less than 7. Now, 8 is what was thrown out by Dr. Paul Mayo in a critical care diastology paper. You can use 8 or you can 7, but as intensivists, we're trying to look for extreme examples. So if it's less than 8, I would be concerned for impaired relaxation. Now, the TR velocity probably tells you a little bit about chronicity, and then just is this diastology impressive enough and significant enough to cause pulmonary hypertension. So TR velocity greater than 2.8 millimeters per second. And then again, this is probably the biggest case for chronicity is left atrial volume index. If it's greater than 34, you know this diastolic dysfunction has been going on for a long time. Now, if you have greater than 50% of these positive, then you have diastolic dysfunction. If you have 50% positive, you're indeterminate, then you can do more advanced studies to look for. But this is kind of the ASC guidelines, and I'll show you kind of like more of a simplified approach. So this is the tissue Doppler, so TDI I was talking about. So you have your 4-chamber view. I am putting my tissue Doppler gate here at the medial annulus of the mitral valve, and I'm measuring how fast it's going up and down. So how fast the tissue is moving up and down. So if you go through this, this is your E prime, this is your A prime. Again, it's analogous to your diastolic mitral and M mode motions as well, right? So you can find that this is your QRS. So this is your systole will happen. This is your S prime. So basically your systolic movement of the mitral annulus. And then around where the T wave starts, you'll have your diastolic phase. So E prime, A prime. So these are the values you're going to be measuring. This is the measurement you would make to figure out for impaired relaxation. This value is 11.5. So you would assume that this person likely has a normal relaxation pattern, therefore no diastolic dysfunction. The mitral Doppler pattern. So this is blood velocity. And so we'll talk a little bit about this going forward, but these are the basic patterns. So your normal mitral pattern is you have an E wave, but basically as your filling pressures in your left atrium rise, as the left atrial pressure goes beyond the left ventricular pressure, because you remember during diastolic phase, your left ventricle is relaxing, your left atrium is filling, and as the pressure in your left atrium rises above your left ventricle, your mitral valve opens, and this blood velocity representation is what you get as your mitral valve initially opens, your E wave. Your initial blood output goes back to baseline, and this is called diastasis before your A wave, and then you finally have your atrial kick. If there was an EKG here, your P wave would be around right here. Right? So this is a normal pattern. Your E is greater than your A. Now, your E, in type 1 diastolic dysfunction, your E is smaller than your A. And we'll go through the physiology of why this is occurring. But this is type 1, type 2, type 3, and then your type 3 has kind of like a restrictive versus a fixed restrictive, which we'll talk about. Right? So let's talk a little bit about the physiology again. So if you are looking at an E and an A, so again, this is a normal pattern. Your systolic, so this is volume, and so if this is LV volume, and so as your LV volume has reduced down, as LV is ejecting and systole finishes, your LV volume is filling up again as your beginning of diastole, right? So your LV volume really jumps up as the mitral valve opens. So again, left atrial pressure goes higher than your left ventricular pressure, your mitral valve opens, and then your left ventricular volume fills up. So your E wave is your initial passive filling, and so you get your rise in the left ventricular volume, and your E wave represents this. Finally, you get diastasis, and then your atrial kick at the end, and this is where you fill up your final left ventricular volume. Your mitral valve closes at that point. If you're looking at pressure, so if you have left ventricular pressure and left atrial pressure on one, and you have your EKG, so again, I am looking at my left ventricular pressure. So This is during diastole again. So my LV is relaxing, and my left atrium at the same time is filling, so the pressure in the left atrium is rising. So as the left atrial pressure goes above my left ventricular pressure, as the left ventricle relaxes, your mitral valve will open up, and then at that point, as the mitral is opening, filling will happening. So left atrium ejects, left atrial pressure drops, left ventricle is filling, left ventricular pressure is rising. So now your mitral valve will eventually close as the pressure overall, as your left ventricular pressure will rise significantly above your mitral valve, right? And so if you're looking at your EKG, around the T wave is around where the beginning of diastole happens. Your atrial kick will happen after your P wave, and after your QRS, this is where systole is going to happen. This is your isovolemic relaxation time. So how fast this relaxation happens and how efficiently is kind of a measure of your relaxation. If this is happening slow and sluggish, you have an elevated or longer isovolemic relaxation time, and that's an indication of diastolic dysfunction. And so this gradient is what makes the E wave happen. So the bigger this gradient is, the bigger this E wave. The smaller this gradient is between your left atrium and your left ventricle, the smaller this E wave is. So as impaired relaxation occurs, this drop down to left ventricular pressure might be lower. So it may stop right here, and you see the gradient might be smaller. Your E wave will get smaller, and your A wave will get bigger, right? So this is kind of how your E and your A happen. So diastolic dysfunction, again, you have your E and your A wave. So what is happening when you compare pressure and volume curve is if this is your normal cardiac function curve, so as the volume is increasing, your pressure is rising. At any given volume, when you have a impaired relaxed left ventricle or stiff left ventricle, this curve will shift up. So at any given volume, your pressure will be higher. So it's all reduced compliance. And so this is how it will look on a pressure and volume curve. So this slide is important. So again, but let's come back to this in a second. So I mentioned before, as your left ventricular relaxation becomes less efficient, the term for this is called negative dPdt. So the negative change in pressure over time. So if you would imagine a impaired relaxation LV or less efficient LV as far as relaxing would relax slower than its alternative. So this takes a little bit longer. Your IVRT, isovolemic relaxation time, is longer, and then your peak negative pressure is lower or is higher as well with the left ventricle because it's not as efficient. This delta will be smaller and your E wave will be smaller. So that's the physiology of why your E wave is smaller than your A wave. In this situation, your delta being smaller, E wave smaller, your atrial kick has to make up for that. So the atrial kick component of left atrial volume reduction is going to be larger, and therefore you have E smaller than your A. So this is stage 1 diastolic dysfunction. Now, most of the phases of diastology, except the restrictive so if you go back to the slide before, so this phase, fixed, restrictive, all these are modifiable, and if you change your volume patterns, typically you can change how this looks at any given point. So any given diastolic dysfunction, if you give them more preload, this can change. So let's say you started off at this A point right here. Your E is bigger than your A, and there's probably impaired relaxation. If I did a tissue Doppler on this person, their tissue Doppler is probably low. Now, if I give this person 8 liters of fluid, I can go from here to here to here. And so this is what the picture will look like. And you can see, as I'm going up, my E to A ratio is changing. So here, my E is this big, my A is this small, and the ratio is much greater than 2. And so that will tell me that my filling pressure, my left atrial filling pressures are larger, and this person probably will end up having pulmonary edema from elevated left atrial filling pressures. But conversely, if I have this, I could probably diurese them and bring them down to here, right? So you can actually follow this over time, and you'll see a difference in it. So as I'm changing this, you'll see that the gradients are changing. So if this is, again, my left ventricular pressure, this is my peak negative right here, If I gave someone a lot of volume, I could move from here to here. You can see this gradient's bigger, and that's why my E wave is bigger. I can bring them down. I can diurese. I can bring them down to down here as well. And so in someone with cardiogenic pulmonary edema, you can see this difference as over time. If you have someone who's on dialysis and you UF them 4 liters and they were up here before you, if you repeat that test, you'll probably see them that they'll come down to here. This is an example of a mitral pattern of post-wave Doppler. And so this is your left ventricle, this is your mitral valve. And so basically it's just right above, a centimeter above the mitral valve. And again, you have your E wave and then you have your A wave. So this is a normal looking pattern. So let's do a case. So you have a 65-year-old male with a history of heart failure, reduced ejection fraction. History, EF's 25%, end-stage renal disease, hypertension, found to be hypotensive. Had HD earlier in the day, but unclear whether he received UF or not. You are called for a rapid response, and you're trying to figure out why this person's hypotensive. So let's assume the patient's awake, maintaining, you have time to do these things. So you calculate the patient's cardiac output. It's low. It's 2.3 liters. You do a Doppler pattern evaluation, and you get this. So you remember, so we go down to your diastolic dysfunction evaluations. I have someone who's older. I have someone with end-stage renal, someone with hypertension. So let's say I didn't know anything about the ejection fraction. Their pretest for having diastolic dysfunction is very, very high. So if I just saw this, I would probably assume that the person probably has elevated filling pressure, even if I knew nothing else except that history. Now, if I look at the ejection fraction of 25%, I know that person has diastolic dysfunction for sure. If you have systolic dysfunction, you have diastolic dysfunction. So I have someone with impaired relaxation, a reduced EF, and then I'm looking at this Doppler pattern. So again, my E and my E to A ratio is greater than 2. So why is that significant? So I'm looking at the E velocity is 151, and so I can tell you that's elevated. Normal is 50 to 80, but again, the number by itself doesn't mean much. So let's see going forward. So what is the diagnosis and the next best step? So if I'm going through this and I'm just taking a test, or I'm actually doing this clinically, I'm trying to figure out which of these is the likely diagnosis. Now, he went to dialysis. I don't know if he received ultrafiltration or not, so I'm still trying to figure some of this stuff out. Now, based on that E to A greater than 2, I have an EF that's low. I have a dialysis patient. The pretest that this person's hypovolemic or dry, left atrial filling pressures are low, it's going to be low because I see this E to A pattern. It's greater than 2. E is really high. I haven't given you much else information. I know my E prime is going to be low because systolic dysfunction pretest for impaired relaxation is high. So I know my E to E prime, which I'll talk a little bit about in a little bit, a ratio, which is an indicator of elevated wedge pressures, is going to be high. I know by E and A ratio by itself, it's greater than 2. And someone with systolic dysfunction, that's a measure that person probably has elevated left atrial filling pressure. So I have elevated likely left atrial filling pressures. So A, I think, is lower likelihood. And if I gave them more fluids, I may worsen the picture. Septic shock, it could be septic shock. But if this is an acute change, and I didn't give you any history about fevers or anything like that, and if you were taking a test and you were asking the nurse, is there a fever? You're asking other questions. If there's no other indicators of that, my pretest for this is a little bit lower compared to my next one, which is cardiogenic shock. I have someone who has a calculated low cardiac output. Now, in septic shock by itself, if you had a relatively preserved cardiac function before, your cardiac output will be normal to high usually. But again, that's a overly simplistic example, which in real life, it may not be built on a test. You'll probably get a higher cardiac output unless they have a additional septic cardiomyopathy. So I have high left atrial filling pressures likely. I have a low cardiac output. C has moved up very high on my differential, right? So I have a 65-year-old with end-stage renal disease, for sure impaired relaxation, likely high filling pressures and a low cardiac output. Sounds like cardiogenic shock, right? So this is kind of what I'm going to be going with at that point. So I'd probably start inotropes and ultrafiltration, and ultrafiltration maybe with CRRT at that point. He has obstructive shock from PE. I have no evidence for this at all. An interesting thing is when you have PE often by itself, and there's no other additional left ventricular pathology, you'll actually see a reversal on this. Your E will be small and your A is low. And again, if you did elevated ED prime evaluation and calculated estimated filling pressures, they'll be low because obstruction prevents filling pressures into the left atrium. So it'll be low left atrial filling pressures, and you may look like hypovolemic if you didn't look at the RV as well. So this is unlikely as well, both on history and also the filling patterns. So the answer is likely C. So what stage and left atrial filling pressure do we have? So we know in stage 1, I showed earlier, the E is smaller than A, so it can't be that. I do have elevated filling pressures. The E is greater than A, so it's either going to be 2 or 3, right? Stage 2 or 3. Stage 2 or 3, or the theoretical 4, where the filling pressures don't really change much and the morphology doesn't change even with diuresis. So 2 to 3 is kind of what I'm trying to figure out. So it could be 2, it could be 3. But my E to A ratio is greater than 2. So if that's the case, typically you're more likely to be in stage 3, so more advanced setting. Your left atrial filling pressures are really high. I already said stage 2 is typically elevated left atrial pressure. So again, if you were taking a test, this would be wrong. It'd be elevated left atrial filling pressures. So I'd already be crossing 1 and 2 out. But typically, E to A greater than 2, it'll be stage 3, and you'll have elevated left atrial filling pressures. So again, we're going down to the mitral. So we did initially a normal ejection fraction. So if we're looking at mitral inflow patterns, if you have reduced systolic function, I don't have it on here. If you have an E to A greater than 2, you have guaranteed elevated left atrial filling pressures, right? So this is assuming you have diastolic dysfunction already. You have a diagnosed diastolic either through systolic dysfunction, you have diastolic dysfunction, or you have normal EF, you've already surmised that this person has impaired relaxation. This is the methods you can go through, try to figure out if someone has elevated left atrial filling pressure. So in our case, E to A is greater than 2, you're already done, so it's simple, right? Otherwise, you'd have to go through a little bit more complicated pattern right here. All right, well, what about this? So let's take the exact same case, but my E is much smaller, 45 compared to 150 before. My E is smaller than my A. Now, if I was going through the same reasoning, again, this is simplistic. It's a reductionist kind of approach, but again, you have to think about this. This is one data point in the whole picture. Now, if I had this picture, I would say that this is probably going to be less likely because the left atrial filling pressure, usually in left ventricular cardiogenic shock, you're going to have elevated left atrial filling pressure. So this is probably unlikely. And you're assuming that I already calculated cardiac output and it's low as well. So if this is unlikely, I crossed that out. Again, I didn't give any history about fevers or anything like that or source. And cardiac output is low. So I would say this is probably unlikely. This could be possible, but again, I didn't give you any history about that. I have someone who's after dialysis. You don't know if they got UF or not, but there may be high likelihood that they had fluid removal, right? So he is in hypovolemic. Likely, I would say if I saw this pattern after dialysis, hypotensive, I'd be going to this picture if I saw this picture, this E to A pattern. So hypovolemic shock, and I would give fluids. So pseudonormalization is a concept. So if you have stage 2 diastolic dysfunction and your E is greater than A, you already know that this person has impaired relaxation. Sometimes you can't tell if it's a subtle case, and let's say you didn't know if you had diastolic dysfunction or not, and you saw this. Is this normal, or is this diastolic dysfunction? If you have them Valsalva, if you give them nitroglycerin, you diurese them, and you got this pattern, that confirms that the patient has diastolic dysfunction. And this is called pseudonormalization. Alright, so let's do the next case. 65, history of hypertension, coronary heart disease, chronic AFib on anticoagulation, CKD4. Presented to the outside hospital, right middle lobe pneumonia, received fluids and antibiotics. O2 demands continue to worsen, requiring intubation. 5 days in the ICU is now requiring 100% FiO2 with 8 of P. P to F is low. It's 120, so severe ARDS. Unclear ins and out balance, weight is up 12 kgs, transferred for a higher level of care. Bedside lung ultrasound, echo are performed. So this is my other situation where I have elevated filling pressures. I have hypoxia that I'm trying to evaluate. So I do my lung ultrasound, so I have my left, I have my right, so there's significant B lines bilaterally, right? So I have a pulmonary edema patterned bilaterally. So now I'm trying to figure out, is that cardiogenic or non-cardiogenic pulmonary edema? Now, I do an echo, so it looks like I have a peristernal lung, look like my left ventricular function is retained, right? So my walls are coming in nicely. And again, you want to make an assessment on multiple views, but let's say I have this, I looked at it short as well, and the EF is maintained. I have normal left ventricular ejection fraction, all right? So I go to the next case, or next image. I go on to do my mitral analysis. So my so if I do my mitral, my E prime is 5. So again, I have my tissue Doppler set here at the left ventricle, at the medial annulus, and it's 5 centimeters per second. So that's low. So remember, the cutoff I use is less than 8. So I know I have impaired relaxation. And I'm doing my E and A, right? So I have my E wave, my A wave. So my E, I already know I have E impaired relaxation. My E is bigger than my A. And so I am at least stage 2, maybe 3. And so now my E to A ratio is not greater than 2. But again, that's more helpful in someone with systolic dysfunction. But I already have diastolic dysfunction. So if this is greater than 2, my pretest would be high likely saying that they have left elevated filling pressure. Next thing I can do is I can look to see what my E to E prime ratio is. Now, E to E prime ratio, let's go back to a flow chart. I didn't really focus on this yet, but so E to E prime ratio is basically the ratio of your E wave, which is your peak mitral velocity using Doppler, blood Doppler, and then your tissue Doppler, so your ratio. If the average is greater than 14, or else I use for the medial annulus greater than 14 as well. I would just simplify it and use the medial annulus, and that's what Dr. Paul Mayo does as well. And so if that ratio is greater than 14, you likely have elevated filling pressures. Now, I'm trying to figure out if this is cardiogenic or non-cardiogenic, right? So if I have my E wave of 147, I have my E prime of 5.23, I know my ratio is greater than 14, right? So it's much, much higher than that. So I have elevated filling pressures. I do a TR evaluation and I see, so my TR velocity is greater than 2.8. So that's a second criteria already. So I already knew I had impaired relaxation from before, where I knew I had TDI was low. And then this is the second criteria you can use for ejection for diastolic dysfunction if you're trying to see if someone has a normal EF and diastolic dysfunction. Now, so I am assuming you guys have had a Doppler talk, and so I'm skipping over a lot of things, and these are complex things, but so forgive me. But this is your tricuspid valve regurgitation signal. So right ventricle, left ventricle, your jet right here, you have continuous wave Doppler, and this is your peak velocity of your tricuspid valve. And so it's much greater than 2.8. What kind of pulmonary edema is this? So likely cardiogenic, right? And so that's pretty much it, guys. So I hope that was helpful. Please email me if you have any questions. And these are my references. Thank you very much.